Good evening all to the 136th session of the weekly huddle. I am your host Anoop, and joining me today is my friend and co-host Praneeth. We both are cardiologists working at KIMS Hospital in Secunderabad. Most of you know the huddle format. Basically, um, what we end up doing is we pick up a clinical scenario that we encounter in our daily clinical practice, and then we kind of discuss this in a relatively informal session where we share each other's ideas. The basic premise is to bring our casual hallway discussion that we typically do with our colleagues into a more organized platform like what this is. It's not a speaker and audience model, rather a casual interaction, which means any one of you is free to raise your hand to add your thought or put on your question. We do want to welcome science, but the part of the discussion in Huddle is how to modify the available science that suits our clinical needs, being more pragmatic in our approach. Because as all of you know that we practicing in India, particularly in the resources that we have, is not necessarily reflective of what the European or the US guidelines are written. And definitely we have to put our own thoughts into place before we use those guidelines at its face value. So with that, I will start with today's discussion. This is actually Praneeth's patient. So I will introduce the case, and then I will ask Praneeth in terms of how he would proceed and what he would do. And then we will take a few more opinions. And then I'm joined with Dr. Haigreve, who is an electrophysiologist at KIMS Hospital. And we will get his insights about this topic also. If you guys missed Dr. Haigreve's oration on sudden cardiac death last Saturday at CSI meeting, I hope CSI has recorded that session and you can attend it, because that was one of the best sessions that I have heard on sudden cardiac death, particularly with an Indian perspective. So Dr. Haigreve, we are proud of you for that. So the case for today is a 62-year-old male. He has a history of diabetes and hypertension, previous history of coronary artery disease, where he required percutaneous intervention to LAD last year when he presented with evolved anterior wall MI. This is his first visit to our OPD. This is Praneeth's patient. I'm using it for my own sake. So this is the first visit to the OPD. He comes to basically he came to ask about his ECG findings, but I'm just telling you the clinical information. So he doesn't endorse any active complaint. He has got baseline class 2 heart failure symptoms. He does not have any angina. He's able to do his age-appropriate activities. He's retired now. He used to own a business, which now his son and his younger brother handles. So all in all, he is otherwise doing fairly well. He also brought with him routine labs, which were quite acceptable. He also brought with him an echocardiogram, where ejection fraction was noted to be 30% with anterior wall, mostly akinetic with certain areas of hypokinesis. His valve functions were otherwise okay. He did bring his old records, which were about 5-6 months back, where the echocardiogram showed a similar ejection fraction of around 30-35% with the same regional wall abnormalities. ECG that he brought in today, and that is primarily the reason why he came to see us in the OPD, the ECG showed sinus rhythm with precordial Q waves. The native QRSs were narrow, but there were 2 wide complex PVCs which were there on the ECG, and somebody told him they're abnormal, so he should go and see a cardiologist. So he basically came to discuss his ECG finding, where there were 2 PVCs. Other than that, there was really nothing else. So while we were doing the clinical assessment, we asked this patient to undergo a SPECT scan to see if there is any reversible myocardium that we can fix. He did undergo an exercise SPECT scan where he was able to meet the target heart rate, and the SPECT scan showed fixed defect in the anterior wall with no major reversibility. And that gave us the reason, no reason to do an angiogram on him. So we didn't subject him to a coronary angiogram. We also did a 3-day Holter to look at that PVC, and the Holter showed less than 1% PVC burden. And there was one run of non-sustained VT where it was mostly 4 beats, and the speed was 162 beats per minute. So that is the background. Now this patient comes to us with the reports that we have asked for, and he wants to know what is the further course of action. He is on most of the cardiac medication that you would expect him to be, along with diabetic medication. I'm not telling you individual details, but I will be happy to share in case if you have a question. So the point that we are trying to discuss is, does this patient fit for offering an ICD for primary prevention of sudden cardiac death? As we all know that a lot of these patients, sudden cardiac death is one of the determinant factor for longevity for these patients. And if you go by certain guidelines, then primary prevention ICD does have a role. It is just that we have to look into, from our practice standpoint, whether we should be offering ICD for these patients or not. So Praneeth, tell me, how would you work up this patient? So far, SPECT is done, Holter is done. He otherwise doesn't have any active symptoms. Would you just give him a pass, or would you do something? Would you not do anything? How would you take up this case? Praneeth, all yours.
Yeah, good evening, everyone. So this patient essentially, is diagnosed to be having heart failure with reduced ejection fraction, stage C, NYHA class 2. Regarding etiology, so far it seems to be an non-ischemic cardiomyopathy. And now regarding the primary prevention of sudden cardiac death, there is significant data in ischemic cardiomyopathy subset, where when patients have ejection fraction of less than 30%, their risk of having arrhythmias and sudden cardiac death is high. So I think the decision of suggesting him ICD seems to be pretty straightforward. But for this subset who is about 62, and so we need to look at the average life expectancy of an Indian male, and equally the overall longevity, probably, and the indication and affordability. So this patient, I would see 62 as relatively young, and I expect him to have at least another at least 8 to 10 years of longevity, understanding that he has a heart failure with reduced ejection fraction. So I'm a bit optimistic that he should have about 8 to 10 years of longevity. Regarding then, so for him, it is young. In addition to targeting the medicines, that is the guideline directed medical therapy, regarding ICD, I would be in favor of giving him an ICD, because he is relatively young and he has reasonable life expectancy. The only factor which I would be probably hesitant will be affordability. So if the patient is okay affording, which in case this patient seems to be affordable, so for me, I would suggest him to go for an ICD for primary prevention of sudden cardiac death, along with continuation of the guideline directed medical therapy. That is my take on this patient.
So Praneeth, I think you by mistake said non-ischemic cardiomyopathy. This patient obviously has ischemic cardiomyopathy. The question that I have for you is, I recollect having discussion with this patient, discussion about this patient with you, and there was some mention of doing cardiac MRI. Can you walk us through your thought process? What are you looking at in MRI? Just for the sake of it, you have an echo inspect finding already. And how things overall modify with MRI?
So MRI, the reason for looking at MRI would be to know for the evidence of scarring. So the presence of scar will be an again a marker for the probably an erythmogenicity, because scar can be a precursor for VT and so-called sudden cardiac death. So if there is a presence of scar, I would be again suggesting, or my threshold will be low for promoting this patient for ICD. The other thing what I was looking at is to equally correlate with the echo findings about the LV ejection fraction and any structural abnormalities, which can help us define the etiology of the cardiomyopathy as well. So that was the thought process. And lastly, the other reason is, once we put an ICD, there can be an artifacts associated with lead. So in case if we want to know any issues, probably it is better to have one baseline MRI to look at his cardiac structure and function, which can help us know the etiology and equally titrate his drugs or therapy in the future. So that was the thought process of suggesting an MRI for him, cardiac MRI.
Last question, Praneeth. The last point that you mentioned, doing MRI after pacemaker or after ICD, aren't these days devices MRI compatible? So you can still do MRI after ICD or after pacemaker?
It's not about the compatibility per se, but about the interference of the imaging with the lead and the defibrillator coil being thicker leads. They may sometimes interfere with the imaging. So that is the reason why I would try to see. And as you rightly mentioned, MRI compatible devices, you can safely do an MRI. It's more about interference in imaging rather than the suitability of whether he can undergo MRI or not.
Thank you so much, Praneeth. I'll continue with my discussion. So the sequence of event that would most likely go is, let's say if Praneeth asks for cardiac MRI or if he offers ICD, there is a good chance this patient is going to go back to his primary doctor or a primary care provider or a general physician and ask for his or her opinion that, hey, listen, cardiologist is asking me to get this, I'm otherwise feeling fine. Is it something which is something that you would suggest? Give me your opinion and whatnot. So we do have Shankar sir here with us. Shankar sir, if this patient were to come to you, please walk us through. One, if you are the primary provider where you are the one who is initially recommending an ICD, or if you are a primary provider where you are giving second opinion to this patient, where the patient has already been offered an ICD by a cardiologist. Please walk us through your role in both the scenarios, how frequently you find yourself discussing primary prevention ICD in this patient subset, and secondly, is it something that you endorse, understanding the Indian practice or understanding the kind of clinical practice that we have, looking at all the practical aspects? So Shankar sir, walk us your thought process.
Good evening to all. I am not an expert in this field of this electrophysiology. Dr. Agrawal is there to guide us. Oh, okay. When such patient comes to me, so where there is an NSVT, we go for a primary prevention of sudden cardiac death. So I advise them to go undergo this ICD. So I refer it to EP specialist to evaluate one more thing. And second thing is, such patients, even the patient has got a chronic heart failure with the LV ejection fraction is 30% here. So such patients also, they are prone for ventricular arrhythmias. So as a preventive aspect, I refer them for either CRT or CRTD. I just, such patients, if they come to me with the ECG of NSVT or couplets or runs of sustained or non-sustained VT, then I refer them to EP specialist for necessary. And if there is a history of cardiac arrest, then post-cardiac arrest, one has to undergo this ICD. There is no doubt about it. But only in this aspect where there is a preventable phenomena is there. So here, and definitely, I do recommend for ICD in this case. The benefits, the long-term complications and all, I am happy to hear from Dr. Agrawal. I'm not an expert in this field, but only thing is most of the times when patient comes to me with this type of history and findings, I do refer them to EP specialist for evaluation for definite ICD. If there is a LBB with left ventricular ejection fraction is less than 35%, I do refer them for CRT also.
Thank you, Shankar sir. Just one question. So this patient, has PVC and has one run of non-sustained VT with a low EF. Here, the decision making becomes a little bit more streamlined. But what is the general practice on the ground when there are patients with low ejection fraction who otherwise do not have any obvious evidence of rhythm disturbance, but they only have low EF? Let's say a patient with a EF of 30%, previous ischemia, now there is nothing reversible, but there is no rhythm disturbance. On the ground, do you still suggest for them to go for primary prevention ICD like what ACC guidelines would recommend? Or you think in India we need to be a little more conservative?
The only thing is this is a little expensive procedure, but even in asymptomatic patients also, the patient can afford. Definitely, we do recommend for ICD, because many of patients are there when they are referred to Hyderabad. They underwent this implantation, and they have come in there. See, sometimes they immediately, whenever whenever this ICD gives a shock, whether the low energy one or the high energy one, they get implanted. So they sometimes they become they experience syncopal attack. So they rush to me, sir, I cannot bear this type of electrical shock. They complained. Then I again refer to the EP specialist for the necessary care. So the patients, especially as a preventive aspect, because of there is a ischemic myocardium is there, as Dr. Pranit alluded to, is there is a scar is there, definitely detectable either by to echo or cardiac MRI. It is a nidus for these arrhythmias. So definitely preventable ICD is I advise. Some people, those who can afford, they will undergo. Sometimes they, those who don't afford, then we put them on amiodarone, beta blockers, and like OS. We treat conservatively. One more thing. I will. I will. Thought process. Okay, this is my opinion, but definitely in this case, definitely I suggest him to undergo ICD, because in the MADI trial 2, where the patients, those who are eligible for ICD, out of 100 patients, the 9 were saved from sudden cardiac arrest or sudden cardiac death also. So that if we go through that MADI 2 trial and other trials, so definitely this prophylactic ICD is essential in this case.
Thank you so much, sir. I will move on, and at this point, I will ask any of the attendees if they have any questions, comments. They can either put it on the chat box or they can raise their hand, and I'll give you a chance to share your thoughts. So, Hagiri, sir, you heard at least opinion from 3 people. I shared my little bit opinion. Praneeth said what how he wants to manage, and then Shankar sir's points. I would like to hear your comments, and I'll give you one more point to discuss. So if this patient was in US, then I don't think there would be any further diagnostics required. There wouldn't be a Holter required. There wouldn't be anything required. A person with an ejection fraction of 30% ischemic background deserves a primary prevention ICD as per the guidelines from that society. And all of these patients, in fact, not putting an ICD, to my knowledge, I have not revised it in the last few months, but to my knowledge, not putting ICD on these patients would be considered a malpractice, at least in the US subset. So walk us through the sudden cardiac death. Walk us through how do you see it in these patient subset? This particular patient, should we directly go for an ICD? Should we go for a CRT? Should we do an MRI and then put a ICD? What is your thought as a general of offering primary prevention ICD in an otherwise absolutely fine patient, but a low ejection fraction of 30-35%? So if you could just give us your thought process. I heard you when you shared your thoughts in CSI, but for the benefit of other people, if you could just briefly mention your thought process and this particular case as well. Thank you, sir.
Yeah, thank you, Anoop. And I heard your introductory comments and as well as the case and the comments by everybody. So commenting from the introductory comments, yours is a great program. Huddle has been a great program and one of the best programs that I have heard as well as interacted. And it is sad that you are not getting the kind of response, but all great things happen like this. So one should not lose enthusiasm and faith in what we are doing if they're doing right. Now, coming to the question of your case, now whenever I see a patient like this, the way we have been taught is to see your patient fits in which trials of ICDs or sudden cardiac death, so that we can make a rational conclusions. It's very easy. Once we know which trial it fits in, we draw the results of that trial and the conclusions of the trial, and we apply it to the patient concerned. And that's how the guidelines also work. Now, clearly seeing your patient who has a myocardial infarction, low ejection fraction, and a non-sustained VT on the PVCs on the ECG and non-sustained VT on the Holter, straight away he fits into the MUST trial. MUST trial was done around 1996, 90 to 96, with a mean follow-up of about 3 years plus 3 years follow-up. And it was not a very big trial. 704 patients were taken. And what happened in these patients were, prior the criteria of the MUST trial, exactly like yours: prior MI, non-sustained VT on ECG monitoring, LV ejection fraction less than 40%, NYHA 1, 2, or 3, and the last one, which you have not discussed at all, was done in MUST, that was inducible ventricular tachycardia on electrophysiological study. So in the MUST trial, if you had a patient like this, there was nothing to discuss. These patients would go into, but this was in 1996, so you'd go into an EP study. If the patient had an inducible VT, you'll put in an ICD. That is what these patients were done. And they did this protocol, and they found almost a relative risk reduction of 24% when patients were put ICD like this, when compared to patients who received beta blockers or antiarrhythmic drugs alone. So this is what very clearly the trials will recommend what to do about this. Now I'll tell you the practice that has evolved along electrophysiology over the last 20 years. Now the thing is, if you have a scar with a patient and you do an electrophysiological study, you will invariably induce a sustained ventricular tachycardia. So now, currently, the last so many years, we have stopped doing EP studies for these patients. We know what is going to come because you do hundreds of patients, and all of them, we know whom will induce and who will not induce. So if you have a scar on the MRI, or a significant scar by means of your echocardiogram, if you assess, you will definitely get inducible VT, so the risk of sudden death. So this patient deserves an ICD. There's no big brainer actually. It is not only in the United States, in India too, these kind of patients would be advised in a ICD. But if you are a purist, you can do an EP study, demonstrate a sustained ventricular tachycardia to the patient's family or to the referring doctor, and then advise an ICD. But I know that you can induce. So having said that, the next thing is, the next point is MRI. Now, the cardiac MRI in these patients are useful for various reasons. One thing is, often it is recommended by good teachers that whenever you talk about ejection fraction, you should always assess or come to the conclusion of EF by at least 2 modalities. There is always a scientific rationale in that, rather than an echocardiogram done by a single person. So that way, one thing is MRI helps there. The second thing MRI helps is the scar. because it gives you an extension of scar. We have seen in our own publications as well as in our own practice, if you have a significant scar that is 6% or more, you certainly have a risk of events. So straight away, you don't need any further thing. That is the second reason. The third reason you do MRI is because these patients, some of them now electrophysiologists, I know that some of them, I'm getting ready whenever I implant ICD, I get ready that they can have recurrent shocks or VT storms. So at that time, if I already have a scar in position, it is easy for me to target how to ablate these patients, the scar-related ablation, scar modification, and all these things. So these three reasons. You can do MRI after the ICD also, but the problem is there's a lot of noise artifacts which will prevent a very good imaging of the heart. And also, if a patient comes with VT storm, that's not the best of the time to take him for a cardiac MRI. So I think pretty much, although Dr. Shankar has been very modest, saying not expert, he pretty much said all the things that I did say with the rider that he's not an expert, but exactly that's how I think with all of you that this is what a case. Any other questions, I'll be happy to answer.
Yes, sir. If you could just stay unmuted, I will ask a lot of questions on my attendees' behalf. But at the same time, I would remind my attendees that if you do have any questions for Dr. Haigreve or as a general, either you can speak it out or you can even put it in the chat box, and I will read it out for you. So, Haigreve sir, you mentioned scar. Is there a formula to say, or is there a cutoff where you say this much is significant? Because every MI patient, if I do an MRI, they will have some scar, right? So is there a cutoff for that?
Yes, of course. See, this is also MRI is a recent technology. Now there have been studies, and there is no this question. There is no guidelines or there is no textbook thing. But the data that we have that has been published all across the world, they have taken a scar of 6%, and in our institution we take a card of 5%, and we have shown it in our publication too. 5% above, the events are significantly. For example, I'll answer your specific question. We had 72 patients with ischemic cardiomyopathy in our own data. So 5% was the cutoff, and those persons who did not have this 5%, their events were 0 at 2.5 years, and the events were 40, and in these 70 patients at the end of 2.5 years. Now coming to the question of scar, every MI has a scar, no doubt. But the thing is, the issue is either a transmural scar or a non-transmural scar. So if you have a transmural scar, that is what is defined as a scar. A lot of patients may get away with early PCIs and this one with a non-transmural scars or a limited scar. So, but is a transmural 5% more is generally considered as a significant thing in all cardiomyopathies, ischemic or non-ischemic.
Okay, so I'll just reiterate what you have said. Subendocardial scar doesn't count. Transmural scar counts, and there it has to be more than 5% of the total myocardium. Am I hearing you correctly, sir?
Correct.
Okay. Then we defined scar. My second question to you related to scar only is, does it really matter where is the scar in terms of your ICD choice, in terms of your decision for ICD? I'm not talking about CRT, but in terms of your decision for ICD, does it really matter whether a scar is in the anterior wall, whether it is in the posterior wall, whether the entire 5% is within one territory, whether there is 2% in various other territories? Does it really matter that?
Well, actually, for decision making of ICD, it does not matter. But for the placement of the ICD lead, yes, slightly it matters. For example, if you have a septal scar, there are two reasons why I would not put it. Generally, we do these days, ICDs are placed in the septum, a screw-in lead in the septum. But if you have a septal significant scar, there are two reasons why I would not put a lead in the septum. One reason is that you will not get good R waves. Because it's all scarred, so you'll have to keep on searching for good R waves and wasting your time. The second reason is more important. Second and third reasons are more important, actually. The second reason is by putting a lead, rarely it has happened. Once, many years back, it happened, is when just at the adjacent of a scar, border zone of a scar, and that precipitated a VT storm for the patient. And all we had to do was just pull out the lead. Very, very scary thing. The third reason I would not put is, now these days ablation is always an important aspect sometime in the patient's life. So if you put a lead there, problem is you cannot go and ablate in and around. You are already handicapped. That areas are all cut off. So it's better to put lead far away from the scar, so that when you have to ablate, you can nicely go and ablate it, that areas. These are 3 reasons.
So your answer brings up another question, which I have typed already as we were discussing, that is lead-induced VT. Now, whenever we are looking at the adverse profile of primary prevention ICD, there is, of course, procedural risk and whatnot. There is future infective endocarditis risk. But one of the risks is, there are actually 2 risks. The risk number 1 is lead-induced VT by itself. So if a patient who gets a primary prevention ICD and gets a VT after 2 months, how do I know whether that VT was actually because of scar or whether that VT was because of the lead that we just put in? That is number 1. And number 2, many of the times these VT, they are self-terminating. They may go for 20, 30 seconds. Patient may not even feel it or may feel a little bit of dizzy, and then they self-terminate. But now you have ICDs which overzealously shock these patients. And of course, with that comes the shock trauma that Shankar sir was mentioning. So I will categorize those as adverse effects of having an ICD. If you could comment upon both of them, lead-induced VT and then these VT shocks, which otherwise would have terminated anyway.
Yeah, the second, both of them are problems. But you see, when you have a lead which is put in the scar zone or the periphery of the scar zone, generally that would cause a VT almost immediately or in the first few days itself, because it started irritating already. So the mechanism is, what actually happens is you are at the border zone of the scar, which is the most area where most of the abnormal potentials are present and the VT circuits are there. So what you're doing actually is, the lead is inducing a ventricular ectopic there frequently, and that ectopic enters the circuit because it's just next to the circuit and quickly causes a reentrant arrhythmia and a sustained ventricular tachycardia. Now, but that would happen almost immediately. It's not something which is happen after a long time. And second, of course, you have the 12-lead morphologies of VTs. If it's possible, it will tell you whether it is coming from where the lead is. For example, if it is in the septum, you know it is a septal VT, narrow QRS VT, or if it is non-septal VT. So these are subtle things that will tell you is a scar related VT or not. And also, it is not a topic, but because it's pertinent, I'm mentioning, in patients with CRT2, there were CRT lead-induced ventricular tachycardias were also reported in the literature when they had this initial CRT implant. So it is a possibility, and this one. The second question is to be dealt by programming. Now, what happens is, if you have a ventricular tachycardia which is short and which is not likely to cause syncope or even a serious problem, and you feel that it is unnecessarily the VTs are overreacting. So what one can do is programming to say that you can make it less sensitive. The ICDs can be programmed in such a way that unless you have 12, you can program it to, unless you have 12 beats, nothing will happen. Until you have 15 beats, it won't act. Or second thing is, you can put it in the monitor zone. Suppose that VTs which are coming are, let us say, 150 or 130 to 150 rate per minute. You can put that in the monitor zone. You can say that ICD will start just observing, monitoring. That means it will tell you that there is, it will record, but it will not act. And you will say, you'll give the direction to the ICD that only above 160, you will start thinking is a VT to act. But below that, you will just record and tell us when we interrogate. So these are the 2 ways in which you can avoid this inappropriate.
Sir, you got muted. Highgrave, sir.
Yeah. No, but I was just finished and muted. So I think I told the answer, right? These are the 2 ways in which you can prevent inappropriate shocks from ICD.
That is correct. And sir, when we talk about appropriate shock also, there is a thought process of programming the ICD in such a way that you let the VT run for a few extra seconds where a patient deliberately faints, so that when you shock them, they don't have that memory or whatnot. Is that a strategy that we follow now? Is it a sound strategy? Does it have a scientific basis?
No, definitely not. The whole purpose of having ICD is to prevent a syncope or even a pre-syncope. So otherwise, the patients lose confidence in themselves, and it will be a catastrophic, impairment on the patient quality of life if these were to happen, because he'll be constantly being worried that he's losing consciousness. Will it shock or will it not shock? So if a VT is long enough that doesn't cause syncope, then you can use this strategy of programming an ICD that it ignores the VT. But that we can do it in slow VTs, like 130 to 150, and short runs of that can be even 15, 20 also. But if it is a fast VT, and then you should never do that. You should actually do it by programming anti-tachycardia pacing, so that they pace the VTs. So these days we have what is called as even VF zone. There is a short run of anti-tachycardia pacing most of the companies have introduced, so that they'll just try a brief ATP even for a VF zone VTs, so that if it terminates, it terminates. It avoids shocks. The avoiding shocks is the dictum, but not at the cost of pre-syncope or symptoms.
Sir, talking about the ICD shock as a general, there is another shift that I saw and would get your opinion. These days, I see a lot of single lead ICDs being placed. During my training, I had unheard of single lead ICD. Most of them had a dual lead ICD, but now, at least frequently, I see there is only one RV lead, and one lead has got both the coils sitting. Sometimes they only have one coil, and they have a coil to can vector. If you could simplify things a little bit so that non-EP guys can also understand, what is your take on it, single lead versus dual lead, if let's say money is not an issue for ICD, and coil to tip versus coil to ring? How do you program your ICDs?
Yeah, the reason why you saw so many dual chamber ICDs were because you're trained in America. The typical American practice have been that you implant a lot of things and then retrospectively realize that you wasted a lot of money and come back to the thing. So you must have been in that phase where that happened. Like the same thing, like they put pacemakers for everybody with vasovagal syncope. After 10 years, they did trials and they said that pacemakers are useless. In India, we never put pacemakers at all for vasovagal syncope all our lives. So that explains why you saw so many. Now, coming to the truth and the science of it is, ICD, when you require, what the trials have shown, they thought initially what the hypothesis was, if you had two leads, you would check atrial fibrillation better, you would have inappropriate shocks less, and all these were the hypothesis. But what actually happened was, none of this happened. On the contrary, the infections increased because you're putting two leads. Lead dislodgement increased because that chance of 2 versus 1 getting dislodged. So the complications increased, and then with no benefit. So it was completely abandoned, the whole idea. So now if you need an ICD, unless a patient has pacing indicate like sinus node dysfunction, pacing indicate sinus node is not CHB. Unless you have a sinus node dysfunction or any reason to pace the atrium, unless you have a specific reason, sinus pauses or need to pace the atrium, all patients who get ICDs get only a single chamber ICDs now. And coming to the 2 coils versus 1 coil, that is not so much of data, but by and large, a single coil lead has been used because lead extraction has become easier with a single coil than two coils. The reason was more with respect to extraction rather than with respect to efficacy. So actually 2 coils logically make the DFT thresholds are better if you have more coils. But with a single coil, the defibrillation thresholds are these days, most of them VTs, we never even do DFT testing, but because they are working with a low level of energy. So a single coil lead and a single lead is the way to go now. For in general, that is a practice all over the world now.
So, sir, just being a devil's advocate now, if you put a single lead and you are saying that, okay, your defibrillation threshold, that is your DFT, these days are quite reasonable, even with even with a single coil. But I go back to basic, something that you mentioned, the arrhythmia detection better. So don't you think having two lead would reduce the risk of inappropriate shocks? Because now with two lead, the device doesn't have to rely upon a far field sensing. It can directly sense into the atrium and give a better differentiation between supraventricular tachycardia and ventricular tachycardia. What is your thought on that?
See, as you know well, in medicine, everything starts with a logical hypothesis, but that has to be proven in by data and trials. Medicine, everything, and many times they don't go hand in hand. That's exactly what happened to the question you asked. This is exactly what the logic, but the trials never showed that the inappropriate shocks decreased by any means by able to do. Because the reason is that your atrial fibrillation invariably led to rapid ventricular rates, and that could be easily picked up by the ventricular sensing if the patients came for monitoring regularly. So that really did not help. And second thing was, at that point in time, there was also a concept of preventive pacing algorithms to prevent atrial fibrillation. Like atrial pacing was used to prevent AFs, and if AF occurred, they used to pace the ectopics and prevent AF. This was a trials that were going on at that time in when 2005 to 2008. But unfortunately, all these were null. They didn't show that any decrease in AF. So that is the reason why all these were abandoned and a single lead is being used.
Sir, last question from my side, and then I'll take up some of the question. I think Praneeth has one question in the chat box. So my question is, Shankar sir mentioned about primary prevention anti-arrhythmic drugs in patients who otherwise do not agree to ICD, or whom we are kind of debating whether this patient is a candidate for ICD or not. Give us your thought on primary prevention anti-arrhythmic drug therapy.
Again, all the MADIT, AVID, CAST, and MADIT, all these things clearly proved that using antiarrhythmics like amiodarone, beta blockers, all these things are no match to ICDs in prevention of sudden death. Well, if you don't have anything, the best drugs are amiodarone and beta blockers. There is no doubt about it. In fact, now the present technology, trials or present data that's coming up is more interesting and exciting. Is that there are trials where the patients are included with scar and VT, scar and LV dysfunction, and they do radiofrequency ablation of the scar and modify the scar so that the ICD shocks are decreased. That it is done for that purpose, but extrapolating it in a country like ours, it is possible, just possible, that you can design a trial where you take patients with primary prevention indications who can't afford an ICD, do a prophylactic ablation, follow them up and see whether these patients don't require ICDs. I mean, this is a very far-fetching, but Western country would never do a trial like this, but we should be able to do a trial where the cost of an ablation is always less than that of a repeated ICDs. So, but having said that, AAD, there is no point also in doing a trial of AAD versus ICD, because it's proven beyond doubt that there is no survival advantage or even equivalency with these two drugs.
So, sir, the question is not about AED versus ICD, and I want your opinion in a way that my attendees can take this message home. AED versus no therapy is what we are talking about. In these patient subset who had, let's say, random PVCs or random couplets, triplets here and there, who has a ischemic substrate otherwise, can we justify putting a primary prevention antiarrhythmic drug, not beta blocker, but antiarrhythmics, versus not doing anything? ICD is not here.
Okay. Now, the indication for amiodarone, the indication for beta blockers, there's no need to tell. Everybody knows that they're 100% included in maximum possible doses in these patients. Now, coming to amiodarone, if you have a patient with PVCs alone, there is absolutely no indication for amiodarone in these patients. With a patient like yours, there is a patient with we are discussing today, non-sustained ventricular tachycardia. Like this patient is practically having a VT. Only thing is we could not find because the period of monitoring was short and there was no EP study. So such patients, if the patient declines ICD or cannot put an ICD, there is a role for using amiodarone in such patients. But definitely no indication for asymptomatic LV dysfunction patients, number one, or patients with asymptomatic only PVCs, no VT at all by extended monitoring also, there is no VT demonstrated, no indication for amiodarone.
Thank you so much, sir. One question that is there in chat box, and this is a more general question. So ischemic substrate anterior wall MI 2 years back, ejection fraction is 35%, checked with 2 different modalities. ECG shows no ectopies, otherwise okay. Does this patient need Holter to establish an indication for ICD or some other test, or just based upon ejection fraction 35% alone, can we offer ICD in that patient? That is the question which is circulated.
Yeah, in patients with anterior wall MI and LV dysfunction, anywhere under 40% or so, and if the patient is having no comorbidities, reasonable longevity of life, expected longevity of life, no CKD, no stroke, patient is all right, and patient has seriously able to afford ICD by either his, that is not a issue, that whether he can afford or not. If these are the things, one should definitely go all out to check out the risk of sudden death in these patients. Now, if a patient has around 35% ejection fraction and primary prevention, I think a extended loop monitoring of these days is very easy, at least for 2 weeks, unlike the past where we has only Holter, should be done to check out for PVC, for non-sustained ventricular tachycardia, number one. And all these patients under 40%, I would do a cardiac MRI now, because that is what was the cutoff in our study too. And we have clearly shown that the cutoff is 40% less. Cardiac MRI scar estimation gives a lot of information to patients. If you have a large scar, and even if you don't have, I think you should, 35%, you should recommend ICDs to these patients.
Again, sir, I'm being a devil's advocate here. You mentioned doing cardiac MRI in patient with ejection fraction of less than 40% or 40%. My question to you is, if a patient's ejection fraction dropped from 55 to 40, wouldn't MRI show a scar in each of them? Like, why wouldn't MRI show a scar? If let's put it this way. If I have a patient with ejection fraction of 35% with ischemic substrate, and if MRI does not show a scar, I will consider MRI wrong rather than the presentation wrong. You get what I'm saying?
That is true. But as if you remember, we discussed about scar being subendocardial versus transmural, right? So it is, you are absolutely right. If you have a patient with Q waves, an anterior wall MI, an MRI shows no scar, there's something wrong with the MRI. You can't have a person with no scar at all. Unless, because if you had reperfused early and if the MI was small, then your EF would have been not been less, it would have been good, right? So I think, you're right. I would not accept MRI if you have an LV dysfunction, anterior wall MI and no scar, correct? No transmural scar.
Right. So subendocardial scar is what you would consider it as a low risk, and there you wouldn't do anything. Am I reading it correctly?
As on no, yes, as on current thing. See, no, you should not get the impression that subendocardial scars don't cause anything. Now, suppose let us go in the reverse way. If a patient with anterior wall MI has a 45% ejection fraction, has only subendocardial scar, but he presents with a sustained ventricular tachycardia. Now, you would definitely put an ICD in them. 45% subendocardial scar, but sustained VT. So there you would not say that he's at a low risk. So you say lesser risk when compared to a patient with transmural scar. That is the way to put it.
Correct, sir. I think what you just mentioned comes into the realm of secondary prevention ICD, and I think that is where the discussion is totally separate. But you did bring up this point that in secondary prevention, we are far more aggressive to put an ICD regardless of what the ejection fraction and regardless of what the scar area is. Sir, in the next 2 minutes, if you could just briefly mention whatever discussion we had, how does it differ when your substrate is non-ischemic? Let's say if a patient comes in idiopathic cardiomyopathy, EF of 30%, similar presentation, does all the rules and all the algorithms that you mentioned, they stand the same scrutiny, or there are certain differences between the two?
Extremely good question, a clinically relevant question. See, because all these, what all you said questions, they came up after the Danish trial. See, before Danish trial, it was considered that whether it is ICM or NICM, if you had a EF less than 30 or 35, you need an ICD, they both are high risk, gone. Now, Danish trial was the first trial which said that in NICM, primary prevention did not show any benefit or not doing an ICD. This was a very revolutionary trial for all the clinicians. People were confused across the world. So that is where the cardiac MRI comes into a lot pictures in Danish trial kind of substrate, that is non-ischemic cardiomyopathy, LV dysfunction. This is when we realize that you can't just banish all patients with NICM as no ICDs. It will be very risky. So it was important to substratify these people. Now, unlike ischemic cardiomyopathy, NICM is a very heterogeneous substrate. In ischemic, it's a very homogeneous. You have a coronary territory related scar, you got a MI, so there is a scar and there is sudden death, there is VT. Whereas in NICM is a heterogeneous subset. There's so many things which cause NICM, not a single condition. So what happens is there are some with a transmural scar, some with a epicardial scar, some with a septal scar, mid-myocardial scars, sarcoid and other things, and HCM, which has got some other kind of scar. So what happens is a very heterogeneous population. So here the importance of cardiac MRI certainly comes in. Now here too we showed, or the rest of the world, like other studies showed, that if you have a scar and a 5% or more even in these patients, then the risk of sudden death is more. So you use MRI to pick up scars and recommend ICDs. So, but having said that, one must remember that in NICM, a lot more patients don't have scars when compared to patients with ICM. So it's a very useful to stratify them separately, because you would be avoiding a lot unnecessary ICDs in the present point in time.
Thank you so much, sir. At this point, I will ask Somaraju sir for his comment about today's discussion and about the patient, particularly if he wants to add anything. Somaraju sir.
Thank you, Anoop, and thank you, Agrawal. And very nice listening to you. And I missed the other day. And having said that, I just wanted to say one or two things. Number one, ejection fraction is an imperfect measure of ventricular function. It has serious limitations. Number one, Dr. Agrawal mentioned that it should be validated by more than one method. I agree with him. And secondly, ejection fraction of 30%, 35% post-myocardial infarction is not a single disease. In as early as 1950s, late 50s and 60s, Eisenstein and his colleagues from Duke University, they came out with a myocardial infarction study at that time, sponsored by NIH. The introductory statement is, myocardial infarction is not a single disease. Similarly, even post-myocardial infarction, 30%, 35% is not a single disease. I've seen significant number of patients in the last 30, 35 years, ejection fractions of less than 30s, 25%, living longer than 20 years. This uncertainty, I'm not saying anything against what is all talked about. What are the uncertainties? What are the unknowns in this area? Accepting that we oversimplify when you name a disease as a disease. A particular name of the disease is not a single entity. I just want you to comment on it, Hagrid. Thank you.
Yes, sir. It's a very what you said is a very insightful statement about myocardial infarction. That and your comments on LV ejection fraction, extremely well taken, and that is what the world over all of them believe, that LV ejection fraction has got a very limited sensitivity and specificity to predict sudden cardiac death. That is the reason why a number of tools were used, or more than 6 to 7 tools, HRV, late potentials, so on and so forth. But unfortunately, trials did not show any use, practical use of this one. And that is why we are left with now an extended loop monitorings and cardiac MRI at the present point in time. I do not know, future may bring out some more things like, as I said in my talk, biomarkers. The most exciting thing is cardiac biomarkers. The microRNA biomarkers is just a blood test. They correlate very well with scar. So if you have a significant number that correlates with a scar, and I mean that if that comes in, It was the most excellent non-invasive tool to predict sudden cardiac death.
I agree, and I just want to ask you and others also, anyone wants to comment, how much of this what we are doing today in this entity is industry sponsored and say the systems of hospital systems sponsored, and if I don't expect any straightforward answer, I just want you to be aware of it. Thank you.
Sir, if I may comment on that sponsored thing, because I saw it relatively. I was relatively close during my training when I was seeing that. It's like love and hate. It's like you can't live with it, you can't live without it. Currently, the overall scenario is such that, I mean, I don't want to take India as an example. I'm sorry to say, but it will be one of the poorer examples. But I'll take US as an example. Over the last many years, the overall zeal of supporting an academic research has really gone down. For various reasons, we can talk about it. NIH is sponsoring the trials, but who is sponsoring NIH? So earlier, NIH was sponsored mostly by taxpayers, but in the last few years, as we have seen, that the federal government's support to NIH has subsequently gone down, and now these are industries which are actually supporting NIH. So the so-called NIH-funded trials in the last 10 years or so are actually indirectly industry-sponsored as well. And the industry is entering only because, or I wouldn't say only because, but a major reason why industry is entering is because like the system itself is not supporting the academic research. And by system, I mean either the primary caregivers or the hospitals or the institutes or the societies. The idea here is if there is a vacancy, somebody is going to fill, particularly if they have business interest. In this case, it is the industry which has business interest. It is modern fact. I don't think we should criticize it. We should acknowledge it, but it is going to live with us. It is going to be a fact. It's like a cell phone and a kid. No matter how much we not like it, that is the fact of it. The modern era kids are going to grow up with screen. So rather than finding reasons how we can ask our kids to get rid of screen, we should rather figure out ways by which we can make screen more productive for them. They're not leaving it. So similarly, rather than, in my opinion, and that is just my personal opinion, rather than thinking of an ideal world where we think that we will hopefully reach a stage where our data will not be influenced or not be supported by or sponsored by industry, we should rather skill up ourselves where we should be able to critically analyze all the data which are coming from them and try to understand which of those data are actually heavily influenced and biased versus which of the data are only sponsored, but the data itself is correct. Just because the data is sponsored, that doesn't make the data spurious. We have to accept it. We have to come to terms with it. We have to skill ourselves up so that we can analyze those data set in a much more better way. Reading abstracts only in the current era is going to mislead us for the reason that you said that majority of the trials which gets published as a landmark trial are industry sponsored trials. So if we only go by abstract, we are going to make fool of ourselves. We have to critically analyze what is going on because industry sponsorship is not going anywhere. It is going to be a fact of our life. Like in India, I can tell you, if CSI starts sponsoring trials, then industry will get out. But I particularly do not think CSI is ever going to do that. That is my thoughts.
I agree with you, Anoop, and nothing much to differ, except saying that at the end of all that, we have serious challenges, what to believe in and what to take, what not to take. This uncertainty continues to be there. And the only thing that we can say is the professionalism and character strengths of the profession of medicine should continue to keep in mind while we are dealing with all this. Thank you.
Thank you so much, sir. Anybody has got any other final comments before I start winding up the session? Praneeth, your closing comments on today's discussion?
I think one of the important discussions about primary prevention, because I think the subset are rather than managing the drugs and supporting them because of the trauma, I think this is something which is often neglected but is equally important. And for a person who is kind of relatively young, sudden cardiac death is a big blow to the family. And I think this should also be a part of evaluation, and I think this has been well highlighted. Yes, definitely not everybody deserves it, but everybody deserves attention, whether he is a candidate for the risk of sudden cardiac death. And I think for that evaluation, sometimes using the special techniques like a cardiac MRI, as highlighted by Dr. Haigreve, seems to be relevant. And in those patients who deserve, I think the ICD should be recommended, and hopefully the cost should come down. And in the grand scheme of thought, that cost is definitely worth a life. So I think as a physician, we should not be hesitant in at least recommending. And I think this should be one of the checklists in evaluating those patients who come to follow up for their drugs. I think this evaluation should be in one of the checklists. That's it, Anoop.
Thank you, Praneeth. Thank you all of you for attending to today's session. We will be back next Wednesday with another topic. Till that time, good night. We'll see you again. Thank you for your time.
Thank you, Umpu. Thank you very much. Bye.